Good morning, everybody. Is this not a fabulous setting on a fabulous day? Just amazing. So welcome to our spectacular New York City and NYU, New York University. We know that there was a little New York excitement last night around Penn Station that some of you experienced personally, others via TV, but in typical New York fashion, there were always traffic snafus, but we're glad you all made it here. So welcome, and know that we did order this perfect weather and perfect view for you to enjoy. So thank you for joining us at our innovative IPE Symposium, Transforming Whole Person Care through Interprofessional Medical Dental Collaboration. It's a mouthful, but as you will see, we do have a lot to say in the next day and a half. This symposium is hosted by our NYU Interprofessional Research Education and Practice Steering Committee, known as IPREP. And at NYU, we are so proud of having been and continue to be an innovation incubator for advancing an interprofessional approach to integrating oral health with overall health. This symposium reflects the leadership commitment to a culture of collaboration by the deans of our 4 health professions schools: Rory Meyers College of Nursing, the College of Dentistry, the College of Global Public Health, and the School of Medicine. And you will meet all the deans in a minute or two. The next 2 days promise to be very informative and exciting, and we have an amazing lineup of national thought leaders from diverse health policy, research, education, and clinical practice systems who are going to create an innovative forum for dialoguing about the best, most effective, evidence-based initiatives and models to advance the integration of oral health with overall health into person-centered care models. Their bio sketches are in your program. We will not be reading them. And even more extensive ones are on our website if you're interested. This program is designed to be interactive, including futuristic keynotes, compelling plenaries, and challenging closing presentations to drive forward our commitment to collective impact. And there will be opportunities to engage in dialogue with presenters at each of the sessions we will have over the next 2 days. We hope that the Day 2 breakout sessions in education, practice, and research, facilitated by national experts, will engage you in examining systems, opportunities, barriers to taking the next steps, and above all, taking and identifying action steps to guide us to the next era of interprofessional progress, collective impact. Now, an event such as this can only be offered with the support of others. The IPREP Steering Committee thanks its sponsors, the Josiah Macy Jr., DentaQuest, Henry Schein Cares, Edward B. Shills, and Pacific Dental Services Foundations, as well as Colgate-Palmolive Company, the National Center for Interprofessional Practice and Education in Minneapolis. Barbara Brandt sends her best regards, and the National Interprofessional Initiative on Oral Health, with Marcia Brand leads, and the New York Academy of Medicine. Their support and commitment to advancing interprofessional collaboration and whole person care has been extraordinary. And we would not be sitting here in this beautiful setting today without their support. And on behalf of our stellar Symposium Steering Committee, who are listed in your program and who I would like to ask to just wave and identify themselves, we offer our personal thanks to each of you for participating. Our conference staff, Anna, Abigail, Michelle. I know Michelle and Anna have been the lifeline to many who are here today over the last few months of planning and getting everybody here. And we have our IPEG, Interprofessional Education Group, student leaders, who are here as well to help guide you, facilitate your progress through the next 2 days. And now I'd like to ask my partner, Dan Malamud, to bring greetings as well. Dan?
Thanks, Judy. So while we were outside, having breakfast, we noted that the birth of this symposium was slightly longer than a human pregnancy. We started about a year ago, and we dealt with so many issues. At least 3 of the meetings were to come up with the name for the symposium. And this, I have to say, reminds me of a story. This is a number of years ago. There was a big medical meeting on the West Coast, and many, many physicians from the East Coast were flying to San Francisco. And so this one doc, and I'll call him Doc 1, was sitting on the aisle and looking at the abstract book. And he looked across from him, and there was a man who I'll call Doc 2 that was also looking through the abstract book. So he said, "You going to the meeting in San Francisco?" He said, "Yep." He said, "What's your specialty?" Doc 2 said, "Nephrology." Doc 1 said, "Right kidney or left kidney?" So the significance of this, if you're wondering, is that I think what's going to happen in the next day and a half, we're going to hear some this thing keeps attacking me. We're going to hear some fascinating stories and ideas and issues, and I think that the bottom line that we would like to come up with is, so what's the value of all this for the patient? And I think we need to keep that in mind. It's fine to do this and to do that and to have your profession at this, but in the end, in healthcare, it's really about the patient. And so that nephrologist has to learn that he's not treating a kidney, he's treating a person who has a kidney problem. Thank you. Don't leave.
Great. Thanks, Dan. And now we'd like to ask our university and school leadership to come up to the podium and bring greetings. So first, Executive Vice President Bob Byrne, Executive Vice President for Health, will be greetings on behalf of the university.
Thanks, Judy. I'm pleased to be part of the Guinness Book of Record longest welcome. It is a pleasure for me to be here and greet you. This is actually part of the DNA of NYU, and it's pleasing to see how many folks nationally believe as well. I want to say a couple things. First, I want to acknowledge the deans who have been participating in this. Eileen Sullivan-Marks from Meyers Nursing, Cheryl Hilton from our new College of Global Public Health, Tom Riles, who's representing Bob Grossman from our School of Medicine, and Charles Bertolami from our College of Dentistry. I also want to acknowledge the person who was my early mentor in interprofessional education and collaboration. That's Mike Alfano, who's here today as well. I want to just say one thing about the substance of the conference. If you think about 4 major trends in healthcare, if you think about increasing IT, pressure on costs, increased risk sharing, and the attention now to measuring quality, all of those should actually work in favor of increasing the interprofessional elements of the way we deliver healthcare. So it should be an accelerating curve over the next few years, and it's exciting to see that the leaders of that movement are here today. Finally, I want to thank Dan and Judy. This is clearly a labor of love. This is, as you know, I'm sure everyone in this room has done one of these. There's a lot of moving parts. But on behalf of Andy Hamilton and myself, I just want to thank you all for coming to NYU, and thank you for all the great work that you do. Thanks.
And we have an exciting week at NYU. This is the week of our new president, Andy Hamilton's inauguration. So this is really the kickoff event for that whole presidential inaugural week. So that makes it even more exciting. Next, I'd like to ask Eileen Sullivan-Marks, Dean of the Rory Meyers College of Nursing, to bring greetings.
Thanks, Judy, and welcome, everyone. It's terrific to have you here. I'm most pleased to welcome you on behalf of the Rory Meyers College of Nursing at NYU. The start of this new academic year marks our first full year using the name of Rory Meyers, which we got as a naming gift in her honor last May from Howard Meyers, a trustee who wanted to honor his wife, who was a nurse and a philanthropist. And I can think of no better way to start this year than with a conference that is, person-focused, interprofessional, and innovative to move us forward in advancing healthcare for all. And we are thrilled to work across schools to support the program that reflects our commitment to our students and to society to bring interprofessional education to the forefront. You are all to be congratulated for your vision and your leadership and the work that you do to address oral health as a core issue in person-centered care. As we speak with families, as Bob was just saying and Dan was reflecting, and we speak with families, we talk among ourselves, we talk among our friends, with our patients, and say something about, oh, we're going to this conference, we're putting this together, we want to bring oral health across interprofessions to the forefront. And everyone, says, oh, what a great idea. And then you hear their stories of the struggles with the family members who are ill, frail, aged, and need dental care of some sort, but they're in a nursing home or they're homebound. Or parents who would love to see preventive care be integrated with their family lives that center around schools, daycare, community, and home. I remember having, two middle school age kids in braces. And I said it was the tyranny of the appointments to get them there at 3 o'clock in the afternoon when I was working full-time or my husband was covering an ER. So it resonates with people that the care needs to be integrated with the rest of their lives. As you well know, what better way to improve lives and quality and health than to be forward-thinking and acting, and we'll do this over the next day and a half. I particularly want to acknowledge, as others have, Drs. Judy Haber and Dan Malamud for spearheading this conference with the planning committee. In particular, Judy's passion for oral health and IPE are a driving force here at NYU, and she's created a team that's taken us all forward. So this upcoming week, as she mentioned, we already had it planned, and then it was announced that it's also the kickoff week for President Hamilton's inauguration. So we just said, oh, well, this is the start today. Because I think it starts Monday. But we said, so you're here to celebrate that. And Bob mentioned that as well. And so we again want to thank our sponsors, and particularly the Macy Foundation and George Thibault, who I understand will be here later today, and to bring this together, because he gave us a challenge grant, and then we were able to drive others to help support us as well. So I wish you a resounding success for the next 2 days, and look forward to being in and out and hearing about it as we go forward. Thank you, Judy and Dan.
Thanks, Eileen. And now Dan.
So I would like to introduce my dean, who's had an enormous impact on my life. I came to the Mass General in the 1970s as an assistant professor of pathology in the Department of Surgery, and almost nobody talked to me. And there was a lab next to mine with 2 young oral surgeons, one Bruce Dunoff and the other Charles Bertolami, who were the only people that talked to me. But more importantly, because we occasionally ate lunch together, and they told me about their studies, and they were studying wound healing in small rodents and rabbits, and interested in the collagen deposition and how long it takes and so forth. And I said, don't the wounds get infected? And they said, no, they never get infected. In fact, in humans, they very seldom get infected. You bite your cheek, it bleeds, it stops, and it's gone. So I planted that in my brain, and I moved from the place where no one talked to me to the University of Pennsylvania, and thought I would be a cancer biologist. But NIH had other ideas. And after 3 rejected grants, I decided I had to do something different. And I remembered the story and said, there must be some interesting molecules in saliva that are keeping the mouth from getting infected. And if I could identify some of those, they could become drugs and could be used in other surgical operations. And so my career shifted from cancer to the role of saliva in health, and what I'm doing now, using saliva instead of blood as a diagnostic. So I need to thank these 2 guys. Thanks.
So Dan used a little inside joke here, because the story he gave actually pertains to him. He was just such a wonderful person early in my academic career who was just tremendously helpful in working in the laboratory. I think anybody that's been in higher education for any length of time realizes that it is just filled with fads. You know, these fads, they come, they go, they get a glitzy title, and then they fizzle. But at least the commitment here at NYU is that interprofessional education and interprofessional collaboration is not one of those things. That it's here to stay because it actually strengthens each component profession, because each of those professions has to have something to bring to the table. So this interprofessional collaborative model is something that we really do think is going to benefit patients in a significant way. And the level of this university's commitment, at least, has sort of congealed in physical form with bricks and mortar in a $170 million building that was the result of collaboration between nursing, dentistry, engineering, and the university, and that you'll have an opportunity to see, I think, either later today and tomorrow at 433 First Avenue. The designers of the building, the architects, were selected because they wanted to promote random collisions of people. That was the phrase they used, random collisions of people for intellectual exploration and discovery, because proximity is actually quite important. So when you're there, either at the reception or at other times that you're in the building, I hope you'll walk from the 2nd floor up to the 3rd floor, and you will see there the most incredible learning commons, we call it, for students. And there you will see nursing students and dental students and engineering students all working in the same space, bumping into each other, group studies, individual studies. And the model that we used was, in my mind, the San Francisco United Red Carpet Club. Because this place is a red carpet club for students. It's got everything except the bar. And there are some students who have suggested that we put one in too. We're going to explore that. And then, if you have the time, go up to the 8th floor and the 9th floor and the 10th floor, and there you will see an ensemble of bioengineering and biomaterials research suites, because dentistry, nursing, and of course engineering are heavily involved in materials now and bioengineering research. And then, as long as you're on the 10th floor, go up to the 11th, and you'll see an incredible conference suite that is used not only and shared by all of the schools, but it is also made available to the university as a whole. Board of Regents sometimes meets in that room, and it's available to the community as well. Finally, I just wanted to say that even though this is an NYU kind of focused symposium in the sense that it's NYU is hosting it, I don't want anybody to think that this place has it all sorted out. I don't think any place has it all sorted out. And I'm pleased that the title is Interprofessional Collaboration and not Interprofessional Education, because while interprofessional education is important, the students are great and they embrace it and they love it. What may be more challenging, and some places where we've made some mistakes, backed off, tried other things, is in the area of interprofessional practice, and particularly in the financing of interprofessional practice. So I hope those are things that will be explored to some extent in this meeting, and we look really forward to the outcome in the hope that we can take some of these ideas and actually implement them. Thank you.
Tom, where are you? I had one of the things that I really liked about this committee was I got to meet people that I normally would not come in contact with. And one of those was Tom Riles, who the first time we met showed me his simulation center. He runs a project that involves several universities in New York City, and it's housed here at NYU. It's very impressive. And so he's had the experience that many of us have not had. And I think he's going to share.
Thanks, Dan. Okay. Thanks. Well, thank you very much. And I'm here really representing Dean Grossman, Dean of the Medical School. And sorry that he could not be here today, but I wanted to thank all of you for being here. This is a wonderful institution. You're right next to one of the oldest hospitals in the United States, 275 years old, I believe, Bellevue Hospital, and great traditions for many, many things. I'm very proud of what Dr. Grossman has done in his 10 years tenure here. He really has transformed our medical school, bringing it up from rankings of 33rd, I think, in the country to 11 this last year, and also has made tremendous strides in making our hospital be ranked as #1 in patient safety and quality. This is not in any small part due to the fact that he's put an unbridled emphasis on education all the way across the board. Some of the innovations that are going on at NYU include we graduated our first cadre of medical students after 3 years of medical school, and these are not people just going into non-clinical practices. They all have high-class residencies, neurosurgery and whatnot. The effort there was to try to reduce the cost and time in medical school and getting on to the advanced training, which has been a very great success. But I think that on the IPE and IPC side, it's been very innovative too. We have developed a number of uses of technology and e-learning for our educational purposes, and each one of those are modules that we teach always bring in IPE. The nurses are there, the doctors are there, they're working together to solve the problems, and students are seeing these from really the first year of medical school all the way through. So I think this has been an emphasis and was mandated that we do that right from the beginning. The other part is the Simulation Center, which you mentioned. It's right next door. It's been open now just starting its 6th year. And not only has this hosted the TOSH program that Judy has been championing, and we just had our 4th event, I believe, this past week or so, where medical students, nursing students, and dental students work together. But also it is a place where we do intense team training for our staff and our residents. Teams from cardiology, from the emergency room, from obstetrics, from radiology even come over, doctors, nurses, students all coming together to train together. And this has been a great opportunity for interprofessional collaboration. Well, I want to thank you all for coming here to this meeting. It's very exciting, and I'm looking forward to it. Thank you.
And finally, Cheryl Healton, the dean of our newest college, the College of Global Public Health, who has been an extraordinary partner across all of our schools. That's a real model of a partnership.
Thank you, Judith. It's very kind of you. You have a very exciting conference lined up for the next 2 days, and I'm sorry I'm not going to be able to personally participate, but I am here to welcome you all on behalf of the faculty of the College of Global Public Health. We have over 150 faculty now. About 75 of those are appointed across 8 different schools and colleges throughout the university. So we truly are, as most schools of public health are, intensely interdisciplinary, and therefore we're very excited when conferences like this are being planned. We're also part of this newly created Faculty of Health that includes the nursing school, the dental school, and the College of Global Public Health. At our end of the spectrum, we are completely dedicated, both here and abroad, to population-level patient care. So for us, the patient is the population and is the policies and the interventions that can help steer the direction of health outcomes, for example, by preventing problems from ever happening. And I know that nursing has a very rich history of understanding that when a patient walks in the door, they come in with all their baggage, all their social determinants, all their context, and that very often is a primary driver. So that is what we're all about, and we are excited that you are looking at the whole person, and we know that those of you here in the room understand the whole person is much more complicated than simply the disease they have. Mahatma Gandhi said that health is the real wealth, not pieces of gold and silver. So your mission in the next 2 days is to advance that concept. I'm sure you will. I'm sure you'll succeed, and I'm delighted to have been able to welcome you to NYU. Thank you.
Thanks, Cheryl, and thanks to all the deans, because they have been true blue in terms of supporting these initiatives. And now I'd like to ask Mike Alfano, because this is the who knew moment, and man, I really have to recognize you, Mike, for one moment, because 11 years ago, when we began this interprofessional journey at NYU, linking oral health with overall health, Mike was the chief visionary, along with Terry Fulmer, in creating this innovation incubator at NYU, and inspired all of us to follow along and take it to the next 10 years worth of steps. So who knew we'd be standing here today with Mike introducing our keynote speaker for this event. So.
Thank you, Judy. As always, you are very kind. When Judy made her opening remarks, she, as most New Yorkers do, sort of bragged about the city, this wonderful, exciting city. And it reminded me of a recruitment process that we went through shortly after I became dean. And we were recruiting someone from the South. And I was worried it wasn't going well. It was terrible weather. His flight was delayed. It just was kind of botched through no one's fault. And years later, I was reminiscing with him. I said, boy, it's great that you came to NYU. I was worried we didn't have a great connection when you came to interview. And he said, well, no, it was. I understood all the problems. We worked through them. And he proceeded to tell me about a cab ride he had. So I thought this was going to be one of those warm stories, how the cabbie reached out to him and connected him to the city. And he said, yeah, what happened was we were coming down 2nd Avenue and another cab cut us off. And I said, well, not unusual. And he said, no, that's not the story. The story is the cab I was in sped up and rammed the other taxi. I said, oh my God, that's awful. He said, no, that's not the whole story. He backed up and he rammed them again. And I said, and you still came to NYU? And I guess that's the kind of magnetism for the right people that this institution can have. And thanks, Judy, for the kind comments. It is very fulfilling to see a crowd like this assembled with all of the discipline diversity in the room, because the start was very difficult. And some of you know that both the American Dental Association and especially the New York State Dental Association tried to shut down the collaboration before it ever got started. There were threats of lawsuits. It was a very ugly time. And I was worried about leading an esteemed institution into a position of disdain. Thankfully, thanks to you, that didn't happen. And what was an outlier has become, in many ways, the future for healthcare. And it's very fulfilling to see that. Now, to introduce our speaker. I first met Harold Slavkin 40 years ago, and I'm not going to take you through 40 years. But what strikes me about that initial meeting is I ran up to him in the hallway of a research meeting, and he was like the rising star in research in the dental profession. And he was actually in the process, I didn't know it at the time, of transforming growth and development as we knew it when I went to school into craniofacial biology. And in fact, reflecting on that time, some 35 years later, he wrote a book called Craniofacial Biology, Birth of a Discipline. And not many of us have the opportunity to sort of birth a discipline, but that's what Harold Slavkin did. Moving forward just a lot actually, when he became director of NIDCR, that's in your portfolio. I'm not going to go through that. What you mostly don't know is that the NIH was very close to closing the National Institute of Dental Research. And it was only under Hal's inspired leadership that he was able to convince his peers at the NIH that it was a worthy cause. And as he was doing this, he finessed a change of the name from the National Institute of Dental Research to the National Institute of Dental and Craniofacial Research. And it provided a more fundamental base in science, and it persists to this day. Part-time when he was doing this, he finessed the situation in which he was able to get Secretary of Health and Human Services to develop the first ever statement, first ever Surgeon General's report on oral health. So no small achievement in a 5-year period. And I might say changing the name took a lot of political finesse because the dentists, once again, wanted to hold on to the dental only. My great gift professionally in life was to receive the benefit of working with Hal for 20 years as a co-founder of the Santa Fe group. And so for 20 years, on at least an annual basis, I've gotten the benefit of his wit, his wisdom, his charm, his vision, his passion, but most of all, his humanity. Ladies and gentlemen, Dr. Harold Slavkin.
Thank you. Thank Good morning, and New York, thank you for allowing me to be part of the New York agenda. For me, it began a mere 45 years ago. I was a newbie, and it was my very first time to New York. I came a little bit early from my village of Los Angeles so I could savor this great city before the conference began. And so I went to one of the classic delicatessens here in New York, and I was having one of these delicious corned beef sandwiches, and I think at the time a Coke rather than a beer. And I finished, and I was reading a book. And the waiter of this delicatessen came over as an elegant representative of New York, and he said to me in this very sophisticated language that New Yorkers use, "Buddy, this is not a library." So that was my first taste of the great city of New York. At that conference, which was chaired by John Converse, at the time the director of reconstructive and plastic surgery at NYU, and a nationally renowned craniofacial surgeon,
who was truly bigger than life and charming and talented and very much an advocate for the patient, for the patient's family, for the community, and for the field. That's fairly unusual for plastic surgeons, by the way, but it came easy to him. And he wanted me to meet somebody at that meeting, and he made a point of creating a luncheon for the three of us. And I sat there, I'm brand new, freshly minted, just finished my postdoc, and they're talking about things that I really had to strain to be connected to, and followed what they were doing. And it turns out that the gentleman he was introducing me to was the first recipient. At the time, I had no understanding of this. He was the very first recipient of a grant from the newly created NIDR, because in the beginning it was only intramural, and then much later it became an extramural program with grant giving and those kinds of things. So I was, what was the grant on and what is it about and so forth. And so the man began to tell me his story, which was intriguing to me. And I didn't fully realize, but by that little get-together, which you're going to have, by the way, during the course of this meeting, you're going to meet somebody you've never met before, and you're going to hear something that you've never heard before, and it's going to change your life. But you're not sure who in the room is going to be the catalyst for that kind of transformation. But it can have at every time we get together. And so if you make yourself available to that, who knows? But for me, it was at NYU, early 1970s, vis-a-vis John Converse, that connected me to the world of craniofacial. It was a new word then. It was coined in 1964 by Sam Pruzansky at the University of Illinois. And Sam had been working on getting other institutions, in particular focusing on NYU and the bigger-than-life John Converse, to join to give leverage and credibility and those kinds of things. So today, because we obviously have a limited amount of time, there are two simple ideas that I would like to explore with you. The first is, on occasion, it's really worthwhile to read history, because sometimes history informs the future. And so I want to bring attention to my little date at this gathering that Converse put together, who is Herbert Cooper. And Herb Cooper graduated from the University of Pennsylvania Dental School, became an orthodontist at the time by doing an apprenticeship, and looked at a map and said, I'd like to open a practice halfway between Pittsburgh and Philadelphia. And it turns out it's Lancaster County, and he had never been to Lancaster. So he goes to Lancaster and he puts it all together, and he's there, and he's noticing that coming into his world are untreated craniofacial deformities, like hundreds and hundreds and hundreds. And he was clueless. The apprenticeship taught him how to straighten teeth, but it didn't tell him how to explore the psyche, the self-esteem, the psychosocial dynamics, and of course, a lip and a palate and swallowing and all of those things were not in his experience. So hat in hand, he went around town, the town of Lancaster, Pennsylvania. It's the epicenter of the Amish community. And he recruited people. You're a nurse, could you give me a hand? You're a pharmacist, could you give me a hand? You do anesthesia, you do surgery, you do prosthodontics, you do pediatric dentistry, you do speech therapy, you do physical therapy. Could you guys give me a hand? And they assembled what he decided to call a craniofacial team. He didn't know the language interprofessional education and patient care. He didn't know interdisciplinary. He didn't know multidisciplinary. He had a societal issue that needed a solution, and he was preparing himself to be a broker to bring together, and rather than a collaborative referral model, he decided that they would be under one tent. They would all see the patient, see the family, look at the timeline, and in that timeline, which for most of these kids is 18 years, realize that there's a sequencing of services, but it's all about outcome. He didn't hear of ACA. He'd never met Mr. Obama. He wasn't aware of any of that activity. He was thinking about it from the point of view of we should be paid by the child who finishes the project, who can speak, who can think, who has a good attitude, who is comfortable in their own skin, et cetera, et cetera, et cetera. Of course. It's intuitive if you're really not involved in a volume-based, procedure-based, how many bucks can I make mindset. And of course, we're looking at the world. The year I was born is when this was going on. That's 1938. Think of the United States in 1938. Still rural, not urban, and in the depths of a depression that required World War II to help it get out of the depression. So in that climate, when people had next to nothing, he was soaring with gifted, intellectual, stimulating mindset, which he completely didn't see it that way. He saw the patient needs to speak. The patient needs to hear. The patient needs teeth and hearing. And by the way, he was aware of mental health. So a protocol was developed, and that protocol is practiced today. So started in 1938. We're now in 2016. There are 250 craniofacial centers in the United States. People do this every day, but they don't call themselves interprofessional education and patient care. They could. And so, in a sense, it is so exciting to someone like myself, although it requires a certain amount of patience on my part. Change is not overnight. It clearly is not something that you can really predict. I'm just reminded from Michael's comments. In 2000, I had been at the NIH 5 years. It was now David Satcher's moment of light to announce the first time ever Surgeon General's report. It was May of 2000. I thought there was very much a God. It was a religious moment. It was a very pretty day in Washington in an elementary school when he was making the announcement and releasing that document. And I thought, you know, a year or 2 or 3, and oral health databases are going to change. The prevalence of periodontal disease, oral cancer, infant tooth decay, blah, blah, blah. Boy, I mean, it's amazing. Here's the document. Here's the evidence. Here's a blueprint to engage pediatricians, OBGYN, midwives, anyone who it is not a monopoly owned and operated by dentists. It is a health problem area that requires a community of experts to come together with respect, with admiration, with knowledge of one another. I was higher than a kite. Of course, as you all know, that same year, unbeknownst to me, was Malcolm Gladwell wrote, published, and we could all purchase The Tipping Point. Surgeon General's report, tipping point, we got it made. I checked off all of the things in the tipping point. We had intuitively touched most of them. We were on our way. Well, 9/11 came, the Depression came, some presidential changes came. What happened to the momentum? What happened to the traction? What happened to that activity? And it's taken longer than Hal would have liked or anticipated, but it's happening. And I believe that we are more than ever before closer to the tipping point. And let me try to make that argument. So these are a typical craniofacial team. And because, as most of you are aware, or if not all of you, healthcare has a federal component for sure, but the states dominate. And it's state by state by state how they get paid. It's state by state by state governing scope of practice. And our country, I mean, in my opinion, is very primitive, arcane, lost in the 18th century. Why not move this thing along a little bit? All Americans should receive high quality, continuous, comprehensive care as Cooper sketched for craniofacial. So the burden of craniofacial, some of you may not be aware, it comes in two flavors. You either come into life with a facial deformity of some type, or in the course of the human adventure, you have an acquired sports injury, automobile injury, somebody with a hatchet comes after you, you know, a New York kind of thing last night, but various things happen along the way. And the burden of that is about $500 billion a year. And about 70% in the United States would be insurance-based, and then there is the floating 30% for others. Today, the field has moved from thinking about the movement of Mendelian genetics, thinking about there's one gene somewhere in the DNA, and in that gene is a mutation or two, and it translates at a particular time and moment in development in which the lips don't close or the palate doesn't close or neither close. And then, of course, there could be a syndrome in which other things happen, limbs, hearts, etc. So all of that is being revisited with the newer resolution called SNPs, single nucleotide polymorphisms. We're 3.5 billion bases, each of us, and within 3.5 billion bases, how do you find one mistake? SNP. That methodology, which was obscure and nobody paid attention until they paid attention, has dramatically changed the way we think about clefting, whether it's spontaneous, whether it runs in your family, whether it's once in a lifetime, etc. So it's also ironic that the grandson of Herbert Kenneth Cooper today runs the Lancaster Clinic. It has been going since 1938, and it's still going strong, connected with Hershey Medical School. And they've modified in which today, because of ACA and other issues, they now do trauma, head and neck cancer, and craniofacial deformities. So the team does that for the reasons of serving the community, the nature of the resources in Lancaster, and those kind of issues. So this represents Ross Long. He's seeing 2,000 patients a year, 18,000 services. They have a grant that started in 1957 to look at the time, in 1957, the language was the etiology and patterns of craniofacial clefting. And the treatment costs there at about $300,000 per patient rather than per year is to achieve the outcomes that they have defined and measured and those kinds of things. It's an excellent model. If you're ever wandering around Amish and you want to check it out, go in and stick your head in and see what goes on there. The IOM, now called NAM, took a look at some of these issues and published in 2003 the report called Health Professional Education, A Bridge to Quality. And in that, they touched upon the theme of interprofessional care and actually had a citation to him. Rick Velikovic at this meeting will tell you much more, but this is the latest 2016 sort of intellectual thinking and efforts that are being made around the country to greater or lesser degree. NYU is very likely ahead of the curve significantly, but it's happening in many places in the country, beginning the process My own university, the University of Southern California, I was led to believe was one of the greatest universities in the world, tends to be a little retarded in this area. We have silos rather than integrated healthcare programs, and everybody has arguments about conflict of time. We could never do it because our schedule is this and your schedule is that. And you've heard, I mean, when you don't want to do something, it's not that hard to dream up a reason. If you do want to do it, then you've got to overcome the hills and valleys and so forth of this. And so here you can see the need. I mean, there's so many moving parts to this. The faculty development, the attitude of students, which affects admissions, the whole issue of cost and revenue centers, and how is that going to work? Because when you are geared up to be rewarded for how many craniotomies did I do this morning, that's my world. And if you change the nature of the game, there's a lot of behavioral pushback, as you might expect, a lot of things that go into play. So when it comes to healthcare in America, I'm focusing on a second idea, which is either called precision medicine, precision healthcare, and it is the idea of, is there a way to improve the quality, it could be universal, but of American healthcare? I was trained to take a patient history, as most of you were. I was trained to ask questions about your mother, your father, your brother or sister, and try to look at, is there a familial pattern around pancreatic cancer or lung disease? And then I was trained to sort through. Now, my training is a few years old. I was trained to think about, is smoking a common denominator? Do you eat lard in great amounts? What are some of the common denominators in the family or community from which you come to this experience and so forth? And so we called that the social history. Some of us got pretentious and called it the genetic history. And we were taught, in my generation in particular, Gregor Mendel meant genetics. One gene, one messenger, one protein was the universe. People got Nobel Prizes for thinking this way. And so that was the world until maybe 2003, 2004, the world changed without notice. And all of a sudden, things began to change in very dramatic ways. And I want to make the argument with you that thinking about modern genomics is in the domain of every nurse, every physician, every dentist, every pharmacist, every physical therapist, occupational therapist, social services, and the larger society. That it's not unique to, if you're a geneticist, you do this, we all do it, because it impacts diagnosis, prognosis, treatment, outcomes, implementation, all are woven together, and I'd like to touch upon that with you. So we understand that we all have high values about prevention, reducing the cost of healthcare. I'm a model this morning for you. I'm the new aging population of America. I am sexually active. I am diversified. I love lots of different things. I do not take medications in any excess. I don't have a bag that I bring to the doctor's office with a collection of pills that I'm taking, those sorts of things. I am robust, at least until the lights go out. And my wife and I have decided we would like to die precipitously when we're 96. So I'm looking at, I mean, it's getting close. I'm because I'm in my mere late 70s. I really have to anticipate what that might be. But the idea of chronic destructive diseases, disorders, losing my dignity, have people take care of that speak a different language is not my life stream. I want to have the character that I have today, the same character applied to when the lights go out. And I think most of us might share that type of thinking. So these are all in play, depending on whether you're a Kaiser person or a Geisinger person or a Cleveland Clinic person. I mean, there's so many different attempts being made. You can have health in your car. You can have health in your home. You can have health on the telephone. There are so many technology-driven ways of approaching the issue. the challenge is to sort that out. Personalized for you. So when you go to Fitbit or you go to the Apple Store or wherever you go, there are devices to give you the illusion that you are in control of your own health care. So these little people are just coming into this world. I've interviewed each of them, and they've told me that they would like mental health, vision health, oral health, and hearing health. And they'd like to live to their capacity. Every single one of these individuals said they do not care for morbidity or mortality, and most important, poverty. They feel that poverty, they've studied society, they are small but bright. They have studied society and have concluded that the number one socioeconomic criteria for bad health in America is being poor. And then this gentleman has strengthened the argument and said, and if you are of color. Poor of color, and then they further taught me that if you're 0 to 5 or 65 and older, you're the most vulnerable. Being a little bit older means in America, 170 million Americans have chronic diseases, including oral diseases. 50% of 65 and older have 5 different chronic conditions and the medication to go with it. 70% of our deaths in America are chronic diseases. 75% of the healthcare bill is chronic diseases. And ironically, 40% of that 170 million people never receive the recommended treatments for their conditions, either of their own volition or the professional. So looking at ourselves as a Western, with a big W quotes, Western industrial country, comparing ourselves to the rest of the world, there is one country who really has a problem, and the country is called Japan. They are living longer and longer than any other culture. They are running out of young people, and the idea of pediatrics is almost non-existent in Japan, and they have these old, very rigid attitudes about immigration. So they live on an island. So you put all of that together, it is an incredible laboratory. They're very well literate, they're literate, sophisticated in many different ways. It's a laboratory that the United States can learn from. It's like you can look into the future a few years because the percentages of aging is strikingly different. We're going to be, by 2050, 90 million people over the age of 65. So when you are an educator, every nurse, every physician, every dentist, every physical therapist, occupational therapist, social worker, et cetera, must have a core background in aging. Aging as not a disease, A, and B, aging with a number of disorders, especially something like one of the fastest growing neurodegenerative diseases is Alzheimer's. And the idea that it has an impact on whether you are practicing dentistry or medicine or public health issues in any of the so-called industrial countries, and it's a matter of time. China used to be called primitive. Today, China is pushing towards, we want a middle class too. We want our kids to play soccer too. We want orthodontics too. And China is now looking at an aging population with all of the attendant issues in which, how do you define work? What is the value of an individual who isn't working? Can they also contribute to the greater society? I would say, of course. Here are the 7 most common chronic diseases and disorders with oral complications. So the idea of, I'm just a dentist, is irrelevant. All health professionals need to have a core background in the human condition. Whether you are a dental person or a medical person or a public health person or a nursing person and so forth. And so here are a number of examples where you'd want to have the dental hygienist, you'd like to have the appropriate dental professional as part of a team to be able to address, because for my crowd, this over 65 crowd that I'm representing this morning, for my crowd, quality of life trumps everything. I could manage my knee, I could manage my back, but I can't manage my psyche. I need to feel that life is of value, important, that I feel connected, that I'm engaged, and all of those kind of issues. So I believe that the time is right now to begin a process in which all of us in the health professions who are on teams learn something new together. By doing that, what happens? We respect other professions we knew nothing about. We find we can learn from other people that we typically wrote off. We increase our insight in a whole set of areas that we've never thought about before. And maybe it's even going to be cost effective, because in the world of craniofacial teams, they have been studied, they are cheaper than taking a child and dragging them to the various specialists at various times randomly that might come up. So there is a precedent, it is in the literature, there's lots of things to look at, it is cost effective. So most of us are very comfortable with basic science. That's kind of like the nerds that I often used to hang out with a lot. And occasionally one of us would get lucky and it would be called translational research, and this could be pre-phase 1 clinical trial, those kinds of things. Clinical research we're very familiar with, but then there is something very interesting. The NIH, I love the NIH. I'm part of the NIH. I have high respect for them. They discovered women in 1990. Do you realize that prior to 1990, there was never a clinical trial that included a woman? Because a woman was considered, until 1990, when the NIH decided they're not just little men. There's something called gender biology. And there are questions connected to females that don't exist in males and vice versa. Ta-da! My wife has been teaching me that long ago. My wife has 2 very gorgeous X chromosomes, loaded with all kinds of genetic information. I have a puny Y chromosome, my inadequacy, which she points out on a regular basis. And so clearly, there is much to learn in between genders as well. But the NIH now, 2 years ago, decided to come up with a new field of study called implementation science. How do you get the findings of scholarship into the hands of poorly educated people of color, people in poverty, who represent a very significant percentage of my state of California, or here in New York, or any major state in the Union? Poverty doesn't skip any of the states of the United States. Whether they're blue or red, they all come with some significant element of poverty. So implementation research, how is the big issue? And I think we're making a little progress. This year, 2016, a synergy has been written about, talked about, conferences between precision healthcare, the genotype of all people, implementation science, and a learning healthcare system, which could be NYU, it could be Connecticut, it could be UCLA, it could be Harvard, it could be, this means a group of professional deans, associate deans, faculty, etc., who think the thought, how can we get better? They are committed to, we're good, and how can we get better? What do we need to do? Learning should be in the mantra of every university in how it runs itself. Having been in the university a very long time, I would conclude it's a new idea in the university system. A chronic learning on the administrative management scale of all of this is a very kind of a new idea. Here is a handbook that you must read. This is required reading for the next time we get together. Came out in July of this year. It's called Applying an Implementation Science Approach to Genomic Medicine. They're using genomic medicine because this is the National Academy of Medicine, but its memberships, I'm a member, there are a number of you in the room are members, it includes nurses, it includes pharmacists, it includes veterinarians, it includes economists, it includes dentists, it includes a lot of people other than medicine. So often the word medicine or medical is a euphemism for saying health or health care. This guy, who I believe in history is going to be looked upon as one of the most remarkable human beings that has touched the planet Earth. In January of this year, he gave the State of the Union and he introduced a new initiative called Precision Medicine. It has 7 components. That was January 20th of this year. He said, we're going to figure out, we're going to get 1 million people to volunteer, and we're going to do genotyping on all of them because the cost of genotyping has dropped profoundly. We're going to then figure out somehow how to develop the mathematics, the algorithms to go from genotype to phenotype. We're going to train people to do a better job on phenotype. This process is called phenomics. And then we're going to make sure that we weigh the data with environment. If you live on one side of St. Louis, a lot of asthma. Other side of St. Louis, no asthma. So there's something in the environment that needs to be looked at. And we're going to look at cell phones and mobile health and and all of those kind of activities. And we're going to do some outreach to the public. And so to get me started, I'm asking for $215 million to come into effect this October, next month. However, the Department of Health and Human Services got so excited, as did Francis Collins, they figured out how to put some money together to move this thing quickly. Let me show you how quickly. So this is what the picture will someday look like. The physician, whether he or she is looking at this, or a nurse, or pharmacist, or public health, is gathering the information, will have the genotype, phenotype, and environmental issues, micro and macro, of an individual, and it will be called precision healthcare, primary care for the 21st century. So again, keep in mind, if you're an NIH-connected person, just think of this timeline. President speaks in January, funding in July. They used DARPA, a Department of Defense mechanism where you get program officers to go out into the country, identify where the talent is, and convince them on a contract mechanism to accept NIH money. So they gave $55 million to the beginning of 1 million American volunteers to have their phenotype worked up. They then gave grants to Columbia, Northwestern, Arizona, Pittsburgh, and the VA, $4 million each, to get started on this process. They also launched $12 million to the African American Consortium for African American breast cancer, highest prevalence in the country. They then went down and gave $14 million to Vanderbilt and Broad in Boston for data analytics in that arena. $20 million went to Scripps in La Jolla to develop mobile and web applications for this agenda. And they convinced the FDA, enough already, get off your ass and work, to do the regulations that would look after DNA sequencing for either doing risk determination or to lead to diagnosis. And that's now been completed. All of that in 6 months. So meanwhile, we have the math of genomics. We understand there's DNA in the nucleus of every somatic cell in our body, in the mitochondria of every mitochondria that came from our mommy in our body, and the microbial DNA, the DNA in the bugs that live on us, which are in trillions, as Dan alluded to, an enormously important part of the human condition, either symbiotic or pathogenic or something in between. We also know that we can resolve this at the level of single nucleotide polymorphisms, in this case looking at 3 people and looking at the 4 letters of the genetic code A, C, T, and G. Is there a change in a particular position, and is it informative? We're revisiting things like spontaneous clefting, and in this case, these particular genes with SNP effects have been found to be what the environment triggers in spontaneous clefting in the kids that are looked at. This was published this year. We also know that there's a clear distinction between Democrats and Republicans. The cytosine found in Democrats is replaced by thymidine in the Republican, and that helps explain. That wasn't explained on Dr. Oz, by the way. They skipped over this information. So here's a group of patients. They all have periodontal disease, or they have cardiovascular disease, or they have some kind of obstructive pulmonary disorders. A lot of people. They're male, they're female. Now, you segregate them by gender, you segregate them by age, but another way to look at them is by genotype, and either high or low responders to a particular therapy that would be cost effective and would give an outcome that would be predictable would be the name of the game. Another way of thinking is to look at these conditions, hypertension, heart, diabetes, tooth decay, periodontal disease, and call it the phenome of someone, and then look down at their metabolism, their protein accumulation, their transcript, messenger RNA accumulation, and of course their genome, and be able to put these, this is the output from the President's initiative when it is eventually completed. And under one of these would be, lots and lots of details. These two people who are very, very talented, Larry Tabak, a dentist, in this case, Francis, a physician, who also is a musician and a Methodist minister. Larry has a hobby as an endodontist and was the director of the Dental Institute. Larry is serving as deputy director at the moment with Francis. They wrote a paper in 2004 in the Journal of Dental Education. Every dentist in education should understand the basics of human genetics. Not a radical idea, published in 2004. Is it a standard in education today? Not as yet. And then in the new NIH-wide strategic plan, which is 2016 to 2020, called Turning Discovery into Health, that's on the web, and there's a wonderful section in it that I'd love for you to look at that talks through their focus on fundamentals versus promotion and disease prevention, and of course working for cures in an area. So there are some challenges, and these are some of the keys. But they're falling into place rather quickly. This, of course, is quite difficult. When you think of going, for those of us trained a few years ago, going from phenotype to genotype means I've got to learn something about genotype. I think I got a handle on phenotype, but I might not know a lot about the quantitation, and maybe my math skills in terms of probability need to be revisited. And of course, this last one, genotyping, a company in San Diego called Illumina, approved by the FDA, is producing genotypes for individuals for less than $1,000 a year. And so that is moving into Medicare and into Medicaid as a benefit. And of course, the society has to be educated, like what in the hell is this, and all of those kind of issues. This is fascinating to me. I live in a community where lots of young people are talking about, we have an autistic child. And so autism comes in many subgroups. It isn't like one thing, as the same might be true of tooth decay is in different types, and also periodontal disease, and also oral cancer. It was convenient at one point for some reason, but there are subgroups. So we know a lot about autism. A lot of groups, especially nursing and occupational therapy people, have really, really looked at autism over the last 40 years and have put data together, and they conclude there are 12 phenotype-based clinical subgroups. So those groups have been selected to do genotyping and see, is there something common within those subgroups? This would be any one of us. We're interested in early detection for breast cancer, prostate, colon, whatever. We want to know something about therapies. I'm going to lose my immune system, my hair is going to go, although in my case it's not a challenge, and all of those kind of issues. So today the tumor, I have breast cancer. They took a biopsy. They looked at all of the genes being expressed in my tumor. They went to the database. They then isolated, and through a process of elimination and the various math that goes with it, they found these 4 candidate genes for therapy associated with networks. They then went further and identified the specific gene and the specific therapy. Meanwhile, Martha Summerman at the NIDCR also has this initiative, and it is her enabling precise craniofacial oral dental health care. Those of you who are interested, and they have their strategic plan and details and literature. And I've just been indicated that the time has come to closure. I'm becoming a memory. Thank you very much. Sure.
Someone passed me a note that time was up and I should stop him. I'm not stopping him. No way. And we did get a late start. You know, that's what happens, you know, when you have an interprofessional meeting, and we have scores of welcomes. So we did get a late start. In any case, we'll entertain questions for Dr. Slavkin. Bruce.
Hal, great as usual. But the last time I heard you speak, you said you wanted to die at age 97, not 96.
Yeah, that seemed too ambitious.
But I would like to address the issue of dental education.
Would you like the mic?
Oh, sorry. The paper in 2004, I think, if I remember correctly, said that there were 9 dental schools that had formal learning in genetics. I don't think that's really increased very much, okay?
It hasn't.
For as long as the culture is what rather than why, we're not going to change behavior. And from my point of view, that's why we're at this IPE conference with nurses and physician assistants taking roles that maybe dentists should take. My question to you is, what can we do to improve that? I've heard people say you learn as much from taking a good family history as you do from genomic analysis today, maybe not in the future. How would you respond to that person?
Well, again, you know, that dangerous word, implementation science. Dan and others have established that saliva is an informative biological fluid, but it's not used. Dental schools do not model the use of it on patients in a dental school environment and the analysis and interpretation. If they did, as a student, when I graduated, the school committed itself to Oral-B toothbrushes. I told every patient that I treated, you must have an Oral-B toothbrush. I recapitulated my background from dental school. When dental schools decide, and you know, you individually and the other deans around the country and your faculties and so forth, that it is of importance, so important to you, that you would like the students to have biological solutions to problems in addition to the excessive commitment to mechanical solutions, prosthetic solutions to problems. When that happens, it's the tipping point.
Other questions? Yes.
Hi, thank you very much. Can you speak to the current enrollment of incoming students and interest in the field of dentistry, and just like your goals and ideals for changing the narrative for the incoming, so that way they have an idea of what opportunities await when they're making that decision? Do I want to go the path of X, Y, Z?
It's really quite good. The applicant pool, there was in the 1980s, dental schools were considered an endangered activity. They have recovered dramatically, and the applicant pool is very robust. It also has changed. When I was a dental student, there was a woman in the class. Today it's 50%. When I was a dental student, everyone did associates and thought about private practice. Today, at the school that I have come from, about 12 of the students went into the Peace Corps, never heard of before. Students are going into the military. Students are going to what they call corporate dentistry, programs that, in a sense, the dentist does the oral health professional part, and a company runs, a corporation runs the business part. A lot of our students are saying, I don't want to be an independent business person, but I want to do this and I want to do other things, especially women who, again, are brighter than men in that setting. So there's some big social changes with consequences to the larger society. What hasn't happened is to really dig into how to reduce health disparities. When you look at the data today, and we did that report and it was published in 2000, it's not better. So that's a window of 16 years. We published something in 2009, and it's painful to work hard. That report took 4 years, and then realize that it has not fundamentally changed. And poverty, of course, is a huge variable.
Dr. Evans.
Yeah, Hal, good morning.
Good morning. Good to see you.
Great to see you always. You know, I come from a perspective, we talk so much about care and patients. And, you know, I come from a perspective that when we have a patient, we have collectively failed because we want to keep that person as a person. And when we become a patient, we fail to prevent. Can you talk about how we can use interprofessional collaboration to maintain people as people and not have them become patients? How do we use collaboration interprofessionally more effectively on the prevention agenda?
I mean, there's a lot to learn from our public health colleagues if we can listen and maybe ask the right questions. Where you're familiar with, this is Kaz as well, and who knows Los Angeles well, the use of Promotora has made a radical improvement for access of very, very large numbers of people. And it is getting comfortable with that this is not about come to my dental office, et cetera, and I might be working poor and transportation is an issue and I don't live and all of that. So the issue is selecting from the community people who have leadership positions, providing the appropriate background. And in some parts of the United States, they're called navigators, health administrators. In Southern California, because of the large Latino population, it referred to as a promotora. That's one big step that in other parts of the developing world, everybody uses stuff like that on a regular basis, and they use different words. It's a person, it's not a patient. So patient is connected with capitalism and rewards for the provider. That's where the word patient comes in. It's not necessary to say, I'm going to care for a community and maybe pay me to keep the community well. It's not about me doing surgery or whatever my thing might be.
Now I have a question along the lines of implementation science, which I'm still trying to grasp fully. But it seems to me it does relate to potential issues with interprofessional education practice collaboration. And that is, you'll have an institution like NYU, like so many others, that work hard to pull the professions together so that patients can have better experiences. But then our graduates go out into a world that is different. Now it's changing, and accountable care organizations, I think, are part of that change. I look and I see a representative from Pacific Dental Services, which is experimenting with putting nurse practitioners into dental practices. I see the chief dental officer of a dental insurance company who's convincing medical insurers that there are savings to be had on the medical side if oral health care is provided. But how do we make this happen faster at the practice level?
I'm guessing. The NIH, I served on a panel recently with the NIH with this implementation science issue. And in the homework that the committee was asked to do, we learned that people learn best from inquiry-based, hands-on learning. So if schools model that behavior and brought these things into the school, there's a clinic that models this behavior. It's a team of people, and it meets because some of these craniofacial teams meet twice a week, some of them meet 3 times a week, some of them meet once a month, again, depending on the demographics of where they're physically located. You can model behavior that you'd like students to internalize and then possibly they'll make a professional selection aligned with, boy, it is great to work with nurses and pharmacists and public health. I had no idea. I want to do that. Where can I go in the country to get more of that?
Other questions? Let me take you back to a Santa Fe group issue, which was the diagnosis of oral cancer. Actually, one of the first things the Santa Fe group worked on. And at the time, 7% of the population of this country, when surveyed, were described what is included in an oral cancer exam. 7% of the population said that they had ever had that exam performed upon them. And at the time when the group was kicking around, what do we do about that, if you remember, our first move, being educators, was it's the darn educational system. We need to do a better job teaching how to diagnose oral cancer. But we quickly concluded that's not true, because there's not a dental school in the country doesn't teach how a proper oral cancer exam should be done. I won't take you through what happened, but it gets to the point I was making earlier. I believe what happened is the young graduates who are well trained in performing that exam went into practices where the exam wasn't performed, and the principal in that practice said, "What are you doing? We don't get paid to do those exams. You're wasting time." And if anyone in the audience has any bright ideas, we'd welcome them. We started a program, many of you know about it, and now we can say with some uncertainty, because the data is not good, that we're all the way up to 25% of the people would now say they've had that exam performed upon them. So at one level, great success. At another level, horrible outcome. Any thoughts? How do we model better behavior, Bruce?
In terms of oral cancer, failure to diagnose oral cancer is the #1 reason for suits against dentists. So fear is one way to deal with this.
Still, we're in the 20s
in education, I
on the exam
understand.
being performed.
The other way, and there's some examples of, teach it to medical students, because a medical student who examines the mouth and finds an oral cancer will never not examine the mouth again.
Other thoughts, Judy?
So your point is so well taken about multiple points about what happens when well-educated health profession students graduate and go into practice. The question is, can you teach an old dog new tricks given the systems that they enter and the rapidity with which they are co-opted into bad practice rather than best practice? So what's your crystal ball about that?
In the room, and because I've had the pleasure of getting to know a number of people in this room, there are a lot of folks who are part of making policy. And anyone who thinks about policy and addresses that question, clearly it's about implementing the data. And the implementation, and there are a lot of moving parts. So if I'm compensated for doing heart surgery, I may push back. So if you're a policymaker, that's a given. Of course there's going to be pushback. So it is important today, the federal government is paying half of America's health bill. 50% is coming out of the Department of Health and Human Services. And that amount may actually grow depending on who the governors and the assemblies are and the games that are being played around the country. So that is an organization that could, through HRSA and through CMS and through a number of those mechanisms, make a very interesting change in aligning with ACA and saying it's outcome. So the question that Mike raised very astutely is, if my compensation for an intraoral examination is based on my reporting of no lesions or something, and if it's not done, then I am in jeopardy. That could change those of us who were born and raised in a capitalistic country.
Final question goes to Dr. Bramson.
Yeah, Mike, I guess the comment I would make to one of the questions you asked is, if dentists say, I don't get paid for doing this, I guess from our perspective as a payer, you are getting paid for doing that. It's part of your oral examination. You should be doing it, and the compensation that you get includes that. We don't break out oh, you get paid to do a caries exam, but you get paid more to do a perio exam on top of that. I mean, you can't necessarily break those apart. So from a payer standpoint, we don't really accept that argument that, quote, I'm not getting paid for that. It's an expectation.
And I don't think you should, by the way.
Right. Well, we don't
But
intend
it
to
is the
either.
argument that's used. Okay, we're out of time. I know there's a few additional questions, but perhaps you can catch Dr. Slavkin at the break. He is like St. Francis. The birds come as he casts the bread for them to eat, and I hope you had your fill. Thank you so much, Hal. Fabulous. Thank you.
Thank you so much, Hal. That was inspirational. And Mike, thanks so much. And now we'll have a 15-minute coffee break. Listen for the chimes to bring you back in to hear our first plenary. Thank you. Thank you. Thank you. Thank you.